to Anna Halpern, if she is on. Is Anna, are you on? Dr. Halpern is a young colleague who is here at our center, who is working really sort of at the interface between myelodysplastic and myeloproliferative diseases, including the indications maybe for transplantation. She is a graduate of Brown University, did her residency at University of Chicago, and then came as a fellow to the University of Washington and the Hutchinson Cancer Center, where she is currently an assistant professor. Anna, it's yours. I think it was recorded. I'm sorry. Yes,
Good afternoon. My name is Anna Halpern. I'm an assistant professor in the Division of Hematology at the University of Washington and in the Clinical Research Division at the Fred Hutchinson Cancer Research Center, and I see patients at the Seattle Cancer Care Alliance. I'd like to start by thanking Dr. Deeg and the conference organizers for inviting me to talk today, and all the patients who are taking time out of their beautiful weekend to attend. Today, I'm going to talk about leukemic transformation in the myeloproliferative neoplasms and myelodysplastic syndromes. These are my disclosures in terms of research funding and an ad board. First, what is the definition of leukemic transformation? This is based on the number of blasts or very immature cancerous white blood cells of these diseases. MPNs can progress to what's called accelerated phase, which means 10 to 19% blasts in the blood or marrow, or blast phase, which is 20% more or more blasts in the blood or marrow. Notably, patients with over 5% blasts are often treated similarly to this group, given similar outcomes, so they are often lumped into our discussion. MDS, or myelodysplastic syndromes, can also progress to acute myeloid leukemia, or AML, and this is, again, over 20% blasts in the blood and bone marrow. Clinically, what does this look like? Patients can present with worsening constitutional symptoms, fevers, rising or decreasing white blood cell counts, worsening anemia, worsening platelet counts, and notably rise of immature white blood cell count on the differential or blasts on the differential of the CBC. And this is how we first might suspect this is going on. And leukemic transformation, which will become important later, is typically associated with the acquisition of high-risk cytogenetic and molecular abnormalities, which likely drive the transformation or increased aggressiveness of the disease. First, we'll focus on MPNs in accelerated and blast phase. So as you likely heard earlier, there are short-term and longer-term sequelae to MPNs. Over the short term, we think about thrombosis or blood clot and bleeding as two major outcomes that we're trying to prevent, as well as vasomotor and constitutional symptoms and splenomegaly. To decrease these symptoms, we typically use aspirin along with cytoreduction, a whole range of drug or therapeutic options that we have. And we're very good at decreasing these risks. Over the longer term, however, MPNs can also transform to myelofibrosis or acute leukemia. And at this point in time, there's not a clear drug or therapeutic strategy that decreases this risk of transformation. There is some intriguing data with the interferons that you might have heard about earlier, but again, not yet clear what can alter the natural history of this disease. So what is the risk of transformation? In polycythemia vera, or PV, about 5% of patients might transform to MPN blast phase, or AML, and another 15% transforming to myelofibrosis. Essential thrombocythemia, the risk is lower, about 5% may transform to myelofibrosis, and less than 5% to MPN blast phase, or AML. The risk is higher with myelofibrosis, about 20%. And this risk is also driven by mutation in cytogenetic data, which we can see later. So MPNs in accelerated and blast phase are challenging to treat. The prognosis in the absence of allogeneic stem cell transplant, stem cells from another person, unfortunately remains poor with about a 3 to 6 month average survival. However, this seems to be improved with transplant. This is a figure on the lower left here from a recently published leukemia paper by Teferi, which was a retrospective or backwards evaluation of 400 patients with blast phase MPNs. The larger figure shows the survival in the Mayo cohort clinic based on treatment strategy. with the top line here being patients who were transplanted, the second line being patients who achieved a remission through therapy but did not have a transplant, and the bottom line, those who did not have a response to therapy or receive therapy. And this is a similar figure, but for the Italian cohort: transplanted, those who had a remission but not transplanted, and no transplant. And as we can see, the overall patients who were transplanted did the best, or even those who did achieve a remission. However, the median survival of these cohorts all remains low at around 5 months, and clearly much progress still needs to be made here. Allogeneic stem cell transplant, or transplant from stem cells from another person, is thought to provide the only curative option in the situation, yet there is no standard or established approach for disease management prior to transplant. Cytoreduction, or the reduction of blast burden, does appear to be warranted, given some studies showing that reducing disease burden or obtaining a complete remission prior to transplant is predictive for better survival. And as you can see, that's a figure on the right, which is showing patients who are transplanted in a complete remission compared to those who are not transplanted in a remission, and those who had achieved a remission first did better. So what are our options for cytoreduction to achieve a remission before transplant? They include hypomethylating agents, which we'll discuss, intensive induction type chemotherapy, or targeted agents, specifically those drugs that target the dysregulated cell signaling in the JAK-STAT pathway. None of these therapies, when used alone, thus far has shown to significantly alter the natural history of these disease. However, data is very limited by few published studies, especially prospective studies or studies that are done in a controlled manner. So what are our goals of therapy in transformed MPNs? The first is to, as we do in chronic phase MPNs, improve the manifestations of the underlying chronic phase of the disease, which are still present even in transformation and can be amplified. These include splenomegaly, or our B symptoms: sweats, bone pain, weight loss. And a second important goal is complete remission, which means eradication of the blasts in the marrow and the blood and restoration of normal hematopoiesis or blood cell development. This is important both for patients who don't go to transplant, because it will improve quality of life, reduce the need for transfusions, reduce the risk of infections, but it's also important for transplant outcomes, because many patients will get a reduced intensity transplant due to age, and thus having a low blast burden for a reduced intensity transplant is important. Because we are targeting two different aspects of the disease, combination therapies are appealing. So this is one treatment paradigm for MPNs in accelerated phase by Marcelino and Mascarenhas, published a couple of years ago. The first decision here is basically fitness or performance status. Is someone fit and has low comorbidities? Then the recommendation is induction chemotherapy, which we'll discuss, followed by transplant. Is someone older or has a lot of comorbidities that limit their functional status? In this case, a hypomethylating agent. Evaluation for mutations in IDH inhibitors, which are common in transformed MPNs, and considering targeted drugs for these, which have been developed and are FDA approved. Clinical trials are always very useful, and supportive care. I did make my own little arrow here because, as we'll talk about, I think hypomethylating agents with ruxolitinib or JAK inhibitors are a very reasonable approach for pre-transplant therapy. First, we'll talk a little bit about the hypomethylating agents, or abbreviated HMAs, often in my slides. These historically have included azacitidine and decitabine. We recently have a new oral hypomethylating agent that has been approved, Inqovi. So azacitidine is given subcutaneously as an injection under the skin, days 1 through 7 every 28 days. It is overall pretty well tolerated. The side effects are mild, include injection site reactions, gastrointestinal side effects, and low blood counts. Decitabine is given IV days 1 through 5 every 28 days and has similar side effect profile. Inqovi is a recently approved version of oral decitabine. It is given in combination with an enzyme, which is in the drug, called sidazuridine, that decreases the body's metabolism of decitabine and allows more exposure to decitabine in the body. And it is given orally days 1 through 5 every 28 days. It has similar side effects to the IV and subcutaneous version of these drugs. However, it's looking like the GI and the low blood counts might be a little bit more pronounced. So what is the reported experience with hypomethylating agents in MPNs in accelerated and blast phase? Unfortunately, the single agent activity leaves room for improvement. Badar and colleagues reported a review of 21 patients with transformed MPNs or high-risk myelofibrosis treated with decitabine. The response rate was only about 30%, and only 7 of these patients went to transplant, but many died after transplant. FIPO et al. Prospectively treated 54 patients with MPNs in accelerated and blast phase with single agent azacitidine, and the response rate was about 50%, and only 10% achieved a complete remission, which is complete clearance of blast with restoration of blood counts, and only 1 patient went to transplant. The median survival was low, only 11 months. Thus, we do need to improve on these single agents. Intensive chemotherapy is sometimes called induction chemotherapy or AML type of chemotherapy. And classically, it's a regimen called 7+3, which is 7 days of IV cytarabine and 3 days of an IV anthracycline, which is a class of drugs that typically includes daunorubicin or idarubicin. We also can use high-dose cytarabine-based regimens, as cytarabine is the main drug that is thought to be very toxic to these myeloid blasts. And these include things like GCLAM, also called CLAG-M or FLAG-IDA. But how successful is induction type chemotherapy in changing outcomes of accelerated and blast phase MPNs? Probably not very successful in altering the natural course of the disease. This was a retrospective review of outcomes of about 90 patients with leukemic transformation and found that AML did not improve survival. The treatment-related mortality or the risk of death with just induction therapy was high. It was about 1/3 of patients, and that is typically the problem. And these patients did not proceed to transplant, hence the low survivals. And that speaks to one of the problems using intensive therapy in these diseases is that intensive therapy can cause very low blood counts, and patients with an underlying MPNs can have a longer time to count recovery, can have issues related to the big spleen, and often have chronic features of the disease that make these intensive therapies harder to tolerate. So what adjuncts can we add to improve responses to either hypomethylating agents or cytarabine backbones? JAK inhibitors are very intriguing, given the JAK STAT pathway is still felt to be active in these diseases. These include ruxolitinib and fedratinib are the FDA-approved ones currently. Targeted therapy, IDH and FLT3 inhibitors. A new drug called venetoclax, a BCL2 inhibitor, which I'll discuss later, as well as clinical trials. We do know that when these diseases transform to AML, they acquire mutations. TP53 is a very common one. It's a tumor suppressor gene. And while we don't have any approved drugs to treat TP53 now, there is an intriguing one in clinical trials, and thus those should certainly be evaluated. There is not much data for the use of ruxolitinib with intensive therapy. De Villiers and colleagues reported a small study of 6 patients treated with 7+3 with ruxolitinib. 2 patients obtained a CR, 2 patients unfortunately died before their blood counts could recover, and 3 patients went to transplant. So really very limited data that we can sort of use to extrapolate. And the concern in the combination is that the intensive therapy causes very low blood counts with ruxolitinib can worsen. Hypomethylating agents and ruxolitinib has been evaluated in several trials for MPNs in accelerated and blast phase, as well as high-risk myelofibrosis and other types of MPNs. Recently, a group at MD Anderson treated 29 patients with AML arising from MPNs with decitabine and ruxolitinib and found responses rates of about 60% in the group treated at the maximum tolerated dose. However, only 4 patients went to transplant, and you can see the overall survival of these patients in this curve. Survival was longer than the historical prediction of 3 to 6 months, but the median survival, even in responders, was only 9 months. And this was likely due to the low transplantation rate. And they did not describe why. Many of these patients did not go to transplant. Overall response rates to this combination have ranged from 24 to 72%, and low blood counts have been the primary issue. And so I think the really key to balancing therapy for the pre-transplant state is therapy that is intensive enough to reduce blasts and get rid of disease, but not so intensive that it causes toxicities that prevent a patient from going to transplant related to low blood counts or infections. So to address this great need for better treatment strategies in this challenging situation, especially pre-transplant, which is the main intervention that seems to improve survival in transformed MPNs, we have developed a clinical trial at the SCCA to specifically treat patients with accelerated phase or blast phase MPNs. This is a 10-day decitabine regimen in combination with a JAK inhibitor. For those of you who've looked up clinical trials before on clinicaltrials.gov, it's a very great website that allows you to look at clinical trials and their eligibility criteria all around the country. And that's the number to search for on that website. The rationale for developing this trial was that this combination has shown synergistic activity in preclinical or mouse models of transformed MPNs. Transformed MPNs often have mutations in epigenetic modifiers and TP53, and the 10-day decitabine regimen has been reported particularly effective in TP53 mutated AML and MDS with epigenetic mutations. Further, as I just showed, there's phase 1 and 2 trials supporting this combination in a non-transplant setting. So our treatment plan is to give decitabine IV days 1 through 10 every 28 days. By increasing this from 5 to 10 days, we allow for more blast reduction, more cytoreduction, but it is not as intensive as intensive chemotherapy or induction type therapy. Ruxolitinib or fedratinib is added orally daily, and the decision between these depends on the patient and physician preferences and what the patient has already been on. And it is allowed for the patient to have already been on ruxolitinib. And bone marrows are done every 2 cycles, and a patient would go to transplant at the best response. And there is no upper age limit for this study. So moving on a little bit to MDS transformation. As you likely saw in the earlier presentations, MDS encompasses a wide spectrum of disease severity. So how can we predict who will transform to AML? One is the widely used IPSS-R risk calculator, which takes blood counts and other disease variables such as cytogenetics and blast level to stratify disease into 5 risk groups from very low to very high, and also provides an average time for patients to transform to AML. As you can see in the highlighted red box, ranging from an average time not even reached for the very low group to an average time of less than 1 year for the very high risk group. The IPSS-R score, however, does not incorporate mutations, and we have been learning in the last decade that mutations can significantly impact disease prognosis in addition to the features that are already incorporated into the IPSS-R score. This group here showed that mutations in one of these 5 genes, TP53, ETV6, EZH2, RUNX1, or ASXL1, are associated independently with worse survival from even what the IPSS score shows. Low risk MDS patients by IPSS scores that have mutated EZH2 and ASXL1 are at higher risk of progression than predicted by their IPSS. And most notably, TP53 mutations are strongly associated with shorter survival after adjustment for IPSS. And you can see a similar theme here to the NPM data that we just discussed. So secondary AML, or AML that arises out of a prior hematologic or blood disorder, is more challenging to treat than de novo AML, or AML that just arises suddenly. The only curative option is an allogeneic stem cell transplant, but therapies range from supportive care to hypomethylating agents and intensive induction chemotherapy, just like in MPNs. Notably, a mutation panel should be done at progression to broaden treatment options. We have inhibitors approved for FLT3, IDH1, and IDH2, and we have clinical trials for TP53, RAS, KIT, and other mutations in development. At the SCCA, we do a panel that includes over 50 genes, and I tell my patients that probably less than 5 of those mutations actually have an FDA-approved drug, but we do have, clinical trials for at least another 10 of those mutations. There is a range of therapy options for secondary AML, from lower intensity supportive care to the most intense stem cell transplant. These include hypomethylating agents alone, hypomethylating agents plus venetoclax, which I will address shortly, hypomethylating agents plus targeted therapy of FLT3 or an IDH inhibitor, Vyxeos, another newer option that I will touch on, induction chemotherapy like we discussed, 7+3 or high-dose cytarabine, and stem cell transplant. However, for most patients, they will need chemotherapy prior to stem cell transplant to reduce the blast burden as close to zero as possible prior to proceeding. So to call out a recent addition to our arsenal, venetoclax is a selective BCL2 inhibitor given orally. And AML stem cells are felt to depend on BCL2 for survival. In this landmark study by DiNardo et al., 430 patients were randomized to azacitidine plus placebo or venetoclax. And they were patients who were felt not to be able to tolerate intensive chemotherapy, either due to age or comorbidities. Complete remission rates were higher in the venetoclax arm at 37% versus 18%, and overall responses were 67% in the venetoclax arm compared to 28%. The median survival, as shown in this figure on the lower left, was longer in this azacitidine plus venetoclax group. However, it was only about 15 months compared to about 10 months, which was somewhat disappointing to see such a short survival benefit after earlier promise in earlier phase clinical trials, which is often the case. However, this is still an important drug in our arsenal. This figure on the right shows which subgroups benefited the most from the combination therapy. These are the different subgroups on the left, and this is the hazard ratio for death, this line down the middle. And that's a common outcome that we use in clinical trials, is what is the risk of death compared to the other arm. And so the dots and bars on the left of it show the ratio, the risk of death is lower in the venetoclax arm, but the bar shows the confidence interval. So if the bar crosses the line of 1, then it is not clear that there is any benefit. And so I particularly called out 2 subgroups that might contain patients who transform from MDS. The first is secondary MDS, is this line here. About 25% of patients in each arm had secondary AML, about 2/3 of whom had prior MDS. And the hazard ratio for death in the combination arm for these patients was 0.56, and so clearly a benefit of this combination. Here is AML with myelodysplasia-related changes, which may also encompass prior MDS. About 1/3 of patients had AML with MDS, myelodysplasia-related changes in each arm. The hazard ratio for death was 0.73, so did show a benefit. However, the confidence interval did cross 1, meaning these findings may not be significant or may be due to chance alone. Vyxeos is another newer option. It's a dual drug liposomal encapsulation of cytarabine and daunorubicin, the drugs that are in 7+3, that delivers the drug in a fixed drug ratio into leukemia stem cells and to a greater extent than normal bone marrow cells, and is thought to be potentially better tolerated than 7+3 because of this liposomal encapsulation. In 2017, Vyxeos, previously called CPX-351, was approved for therapy-related AML, which is AML due to prior chemotherapy or radiation, and AML with myelodysplasia-related changes, which may encompass much of AML that arises from MDS. This was based on a phase 3 trial, randomizing about 300 patients to Vyxeos or 7+3. The overall remission rate was 48% in the Vyxeos arm compared to 33% in the 7+3 arm, and it appeared that remissions were better quality or deeper. Vyxeos also significantly improved survival compared to 7+3. This is the blue arm is Vyxeos, the yellow arm is 7+3. The median was only about a 4-month difference. However, this difference persisted after transplant, with Vyxeos again being in blue, and more patients overall were able to get to transplant again.